Hi, I'm Eleftheria and I'm a massage instructor. In this video, I will talk about massage therapy and frozen shoulder. So, frozen shoulder, also called adhesive capsulitis, because that's what it is not a myofascial condition at its core. Actually, it's a capsular pathology involving chronic inflammation and subsequent fibrosis of the glenohumeral joint capsule. In the early freezing stage, synovial inflammation leads to proliferation of fibroblasts, increased type 1 and 3 collagen deposition, and capsular thickening, especially in the anterior structures like the coracohumeral ligament and the rotator interval. Pain at this stage is primarily driven by chemical irritation of intra-articular structures, not muscle shortening. Thus, deep tissue or aggressive stretching here can exacerbate the inflammatory process. As it progresses into the frozen stage, we see capsular contracture, particularly limiting external rotation due to the involvement of the inferior glenohumeral ligament complex. Only then does muscular adaptation follow, especially in the deltoid, upper trapezius and pec minor, due to the compensatory movement. Massage, applied with clinical reasoning, should focus early on pain modulation and later on restoring scapulothoracic rhythm and addressing secondary myofascial holding. Misidentifying this condition as purely muscular leads to ineffective and potentially harmful treatment. Hey, by the way, don't forget to have a look at my books on Amazon. You will find me there as Eleftheria Manzoru. Now, let's talk about what a massage therapist can do for a patient who suffers from frozen shoulder. Massage for adhesive capsulitis should never focus directly on the glenohumeral joint during the early inflammatory phase. Instead, it should be applied to the surrounding compensatory structures that become overloaded due to restricted shoulder mechanics. In the freezing phase, work should target the upper trapezius, levator scapulae, supraspinatus tendon region, with a bit of caution of course, the suboccipitals and paraspinals from C4 to T4 to address cervical thoracic tension from guarding and postural adaptation. Of course, gentle effleurage and pain modulation techniques may also be applied to the deltoid region, avoiding any deep pressure near the anterior capsule. In the frozen phase, treatment can expand to include pectoralis minor and major, serratus anterior and the rhomboids, aiming to restore scapulothoracic mobility. Cross-fiber friction and myofascial release may be used judiciously on infraspinatus and teres minor, once passive external rotation begins to return. The goal is never to force glenohumeral range, but to improve the mobility of the surrounding kinetic chain, especially scapular motion and thoracic extension, so that as capsular restrictions resolve, the rest of the system is prepared to support functional movement. Always match your approach to the phase of pathology. And always recommend people to start a physiotherapy program that will include gradual stretching and strengthening of the muscles of that area. Hey, thanks for watching. Don't forget to subscribe to the channel for more and also like this video. Be always healthy and happy.